Right, so this first poster was an audit we carried out on pre-operative pregnancy testing, looking at adherence to guidelines in our institution. In general, it's based on the fact that NICE guidelines recommend that any patient who's of childbearing age should be assessed and counselled for pregnancy prior to any induction of anaesthesia. Incidence of anaesthetic surgery is pretty low, it's less than 2%. However, any procedure that requires anaesthetic, a patient of childbearing age should be aware of the risks, should and undergo a test for pregnancy as well. Looking at the adherence in our institution for pregnancy testing, we found that the manner in which we collected data was we carried a retrospective analysis at 39 randomly selected cases over a 1-month period. We were looking at any patient who required general anaesthetic. The duration of induction emergence was over 30 minutes, and given there's no guidelines, there's international definition for age of pregnancy, we based it on whether it was documented in the anaesthetic or theatre care plan, whether they were of childbearing age. Looking at our results then, the age range did vary a lot between 16 and 46. The minority procedures were emergencies, so only 20%, where the rest were elective. In 7 cases, there was exposure of the patient to ionizing radiation, and we found that of all these cases, all were asked if they were pregnant. However, only 82% received a pregnancy test, and general anaesthetic was used in all of these cases. So overall, the outcome of this is, while there was good adherence to asking patients whether or not they were pregnant, there wasn't uniform testing across the board. This is very important because patients can be unaware if they're in an early stage of pregnancy, or they can be unaware of the implications of pregnancy and whether or not they'll disclose it. So second issue was that the institution, while they were asking every patient with regards to whether they might be pregnant, there was no documentation available on whether the patient had been counselled on the risks of anaesthesia to pregnancy. This is something that is recommended by NICE guidelines, and it's something that we would like to add if we were to complete the audit cycle, and with regards to education of healthcare staff.
Sorry, I'm just muted so you would avoid background noise while you were chatting. Really interesting. So can I ask a couple of things? What was, you broke up slightly, we were going through the methods bit. What was your definition of childbearing age? What age range did you encompass?
We based it, there's no strict definition. There's no strict guideline. So we based it on whether or not the healthcare staff found the patient to be potentially of childbearing age. So previous audits that I've looked through showed the average age to look at is between onset of puberty, so 13, 14 to 40, 48 or so. And really in every case, it was based on theatre care plan, anaesthetic records. Was there a member of healthcare or staff member who thought there might be a risk for pregnancy in this patient?
So, so is it possible that there were other patients in the same age group who weren't identified because they weren't identified as being of childbearing age? So that, you know, a 30-year-old woman who someone just forgot, therefore they wouldn't get into the audit.
There is potentially, yeah.
Okay.
Sorry, you broke up a little there, but there is potentially a risk, yeah, and that's one issue. That's a problem.
I mean, it might. I don't know if you're going to go on and publish this or anything, but it might be worth understanding what the true. If you said it's 16 to 50 or 16 to 48, how many patients you missed because of that particular definition? It would be interesting to know. The second thing, you're a doc, you're a physician.
Yeah.
Yeah. Like 100% is unusually good for doctors. We're usually not that reliable. Do you know who it was that identified, who asked the question about pregnancy? Was it the doctors, or was it actually In most cases, or every case?
Yeah, almost every case. Yeah. um, it's the nurses who are accurate.
Right, but so they're definitely
not the doctors, so, unfortunately.
100% is brilliant. But then the test, I think what you're saying is there's very little documentation. So some of them get a pregnancy test, but if they don't, there's not good documentation of why, whether there was an informed consent discussion, whether they rationally declined consent, or there's nothing there.
So yeah, there's no record, and then also we would check if there was any evidence of like urinalysis with beta HCG or any evidence of blood serum beta HCG on the system, and if there are neither, well then.
Because that's probably, I mean, if the non-physician identifies they might be pregnant, they get a pregnancy test, and they're happy with that. That's cool. But the remaining 17.9% who didn't get a test, who might have been pregnant, that presumably should have been discussed more and documented and explored. And I mean, it's acceptable if they don't consent to a test, but it's uncomfortable.
Absolutely,
yeah. Yeah, that's a really interesting audit. I don't know if I'm reassured that I was right about the nurses. It's just thinking back to when I was doing a lot of emergency anesthesia, it was very often that it wasn't necessarily us that remembered it. Yeah,
and it's true in most cases, I have to say.
Good. Okay, very interesting. Second poster?
Sure. I'll move on to it now. I'm just trying to.
If you go down the bottom left, there's a little, you see the symbols appearing?
Sorry?
Bottom left, there was a little arrows to advance the slide.
Okay, it's a different PowerPoint, so I'll try it now. There. Oh no.
That's the same one.
Sorry.
This is it, isn't it? I can see pre-operative fasting.
Yeah, that's the one.
We're there.
Hello.
Okay, pre-operative fasting. There, can you see that now?
Yeah, all clear.
Okay. Right, so this audit, let me just put this down. This audit, really, we're looking at pre-operative fasting, seeing how our institution compared to guidelines. Again, AAGBI, they recommend pre-operative fasting for all patients. There's always a risk of aspiration without pre-operative fasting. And in general, the guidelines as of 2011 are 2 hours for clear fluids and 6 hours for solids. This varies in children, of course. Prolonged fasting times, there's many risks with them. They include increased anxiety, increased hospital course, also risk for post-op nausea and vomiting. And overall, this audit was built off guidelines from AAGBI, Cochrane, and ERAS. The methods for this audit were 41 cases were randomly selected. It was over a 1 month period, and it was a retrospective analysis. It was in the same institution. A variety of patient demographics was recorded: surgical procedure, duration of procedure, general demographics. We also looked at whether they were fasted both to fluids and solids, or and if they were prescribed inappropriate fluids, as well as if they had any certain risk factors such as reflux symptoms. Any pediatric cases that were duration of less than 30 minutes, or in particular, were excluded. Looking at the results, then the patient age range was quite wide. It was 38 to 77. It was almost even. It was 30% male, 70% female. and we found that the average length of time for fasting to solids was 12 hours, with only with 92% of patients fasting over the recommended guideline of 6 hours. One patient in particular was fasted for 20 hours, and only a minority were near the guideline of 6 hours for solid food. While our institution was great at uniformly fasting patients, there was definitely longer fasting times for the majority of them. The guideline of 6 hours and 2 hours for fluids includes the fact that, as per ERAS specialty guidelines, patients should have carbohydrate-rich drinks, 400 mils, 2-3 hours pre-op. This was something that, again, was variable in terms of which patients received this. I believe major factors for the difficulty in fasting according to those strict guidelines of 6 hours include it's very difficult fasting times individually to patients as a case list proceeds. However, there's also other things such as general nursing staff and healthcare staff education on fasting, along with cancellations and things like that with patients. So really, for this audit to improve over time, we'd be looking into providing education on guideline times for preoperative fasting to healthcare staff and see if there was any improvement.
Great. Thank you very much. So that you give the solid times. What did the fluid times look like? Do you have a feel for that?
So appropriate fluid fasting times.
The average length of time for fluids.
Yeah. I only have the percentage here. I must have I don't have the actual numbers, but I know in terms of fluid fasting times, 5% were appropriate and 95% were not. So they were over 2 hours. I mean, I do a lot of work around oxygen, and you see, so we typically set a lower oxygen alarm, or say keep it above, but we don't often say keep it below. And if people typically do what they're told. So if you just say you can feed up to 6 hours, but don't say up to 6 hours, but not more than 12 hours, then they tend not to worry about it so much. It's actually better. It's like I've seen posters like this probably over the last 15, 20 years. You see one every now and then, and this is better than they used to be. We used to be quite common to see like 24 hours plus. Okay.
So there's cause to be optimistic in life, but but it's still a bit of a concern. But I'm more concerned about the fluid. We all can get by without solids for 12 hours because we do quite often. Oh, depending on when you have your breakfast, but the no fluids thing is a bit more of a concern, particularly when you're moving into a situation where hypovolemia might be a big deal. But
absolutely.
And are you going to close the loop and do it all again? See your advice.
That's the goal, yeah. So that's really what we need to do to finish this audit. Would be to close the loop and repeat it after providing information to nursing staff, 6 hours, 2 hours guidelines.
Good luck. It's a big lift. It's always challenging to change behaviour.